Welcome to the next episode of Mic'd Up with Chiro Up. I'm your host, Brandon Steele. Today's episode is going to be in 3 segments, like they all are, and this is going to be another special episode. Special because we get someone besides Dr. Bertelsmann. In all honesty, he is in South Africa giving a lecture, a 4-day lecture on chiropractic care to the South African Chiropractic Association. So we're super excited as a company to have him there and representing us. However, I get the latitude to bring in someone else as a guest contributor. And I brought in Dr. Brennan Donahue. Now, Dr. Brennan Donahue is a chiropractor in the St. Louis area. He is one of the first people to use our EHR, and, which makes him special, he has actually treated parts of my family. He has worked on my son after a hamstring tear using Shockwave therapy, and I want to have a quick discussion with him over how do you start incorporating Shockwave therapy, how he's actually marketing it, and I think that's going to be something that we can all learn from, not necessarily on Shockwave, but how can we add on services into our existing practice. Once we get done with that conversation, I'm going to cover the 6 things that I learned from that presentation and uncover how I actually use those things in my office as add-on services. Now, add-on services for us could be dry needling, it could be extra supplements, supplies, or things like Shockwave, essentially the non-billable services that we incorporate in our office that people are paying cash for. Now, before I go into his interview and before I dive into my 6 lessons that I learned from the interview, I want to cover one thing that I think will blend all these things in together. Because I wrote a blog about 2 weeks ago on weakness. Weakness as far as what are we feeling with orthopedic testing when we sense weakness in that range of motion while testing that muscle, that ligament, that tendon, whatever it may be. And I think I want to cover that first because that's going to lead into this conversation with Dr. Donahue and when we talk about tendinopathies. So to start this podcast off, I want to talk about pain and how does pain behave when we're dealing with tendons, because I think this is one of the things that is mystical, at least when you're first working with patients, kind of understanding, is the patient's pain actually behaving like the tendon? Because one mistake that we can have, especially with chronic tendinopathy, is assuming that pain is a direct measure of what is happening mechanically inside the tendon. It's not. It's 100% not. And that's not an opinion. That's what the facts are telling us. That's what the research is saying. Because if we can understand this simple sentence, then it's going to completely change how we examine and how we rehab these patients. So I want to cover 2 terms, and these 2 terms are going to be the theme behind the entire podcast, and it really is understanding nociceptive versus nociplastic pain responses. Now, those are big words. If I had to say them 5 times fast, I'd probably have a little bit of difficulty. However, I'm going to explain them, and then we're going to dive into what this actually means in the podcast. I think that these are 2 pain mechanisms. Let's talk about nociceptive pain first. Nociceptive pain makes intuitive sense to most of us. And what this means is when you load an irritated, a sensitized and injured tendon, that those peripheral nociceptors are going to respond and the patient experiences pain. So if you add more load to an injured tissue because it has a tear, a partial tear, an injury, whatever it is, the more provocative load, the more pain that someone has. If you put less provocative load, then they have less pain. That makes complete sense. That makes 100% sense. However, it's not the way the body works. It makes mechanical sense. However, if you're a biomechanist out there, you can draw this message on a chalkboard, you can graph it out, and there's all calm in your world. But you and I know that we can see disasters in an ultrasound, disasters in an MRI, and someone doesn't have a lot of pain, or the exact opposite is true, where we have tons of pain and we can't find anything mechanically wrong with someone. That brings us into the second part of this podcast. Second theme would be nociplastic pain, because this isn't just a little different. This is a lot different. This isn't different because it's hard to explain. It's very abstract, but it's not magic. It's not mystical. It just means that there are a lot of moving parts. There are a lot of different systems that can influence the pain experience. And now here, altered pain processing becomes a much larger part of the experience. The nervous system response is increasingly influenced by factors such as expectations, such as the perceived threat of the load, fear, prior experiences, poor sleep, high stress. There's a lot of different things can impact someone's perceived pain. Now, it does not mean this, because this is the one thing that I hear from other chiropractors, from PTs on social media, is when someone says the pain is psychological, the pain is in your head, the pain is imaginary. Their pain is real. If you take a look at any one of your patients, besides Carol or Sally, who's, you know Carol and Sally when they come to their office and they circle the entire body picker, they could possibly have some psychologically induced pain. However, for the vast majority of our patients, this pain is correlated to a mechanical problem. However, they have now catastrophized this problem. There's multiple systems resulting in pain. Now, the reason I bring this up is because here is a simple clinical experiment. Here is a simple way to understand this that is going to help you understand the meaning of your orthopedic test and also how you're going to rehab someone. Let's say this. Let's say you put someone in a very safe isometric knee extension, or you put them through a load. Let's just call it an isometric knee extension. It's kind of simple to understand if someone has like patellofemoral pain syndrome. Well, if you put them at, let's say, 20% effort and they report a 2 out of 2 pain, okay. What if you add it to 40% effort and it goes to a 4 out of 10 pain? Heck, what if you go to 60% effort and it goes to 6 out of 10 pain? Well, that doesn't necessarily diagnose nociceptive pain. However, there's a really strong relationship to a mechanical problem in this situation. The more load, the more pain. And I think that this is a very acute type situation where the person just hurt themselves. And as you increase tendon or mechanical or muscle load, you're going to increase symptoms. We've all seen this patient. Now imagine the next patient that walks in your room. You do the same isometric knee extension and 20% load produces 7 out of 10 pain. Then you increase load a little bit more and they're still at a 7. And then you increase some more and the pain drops to a 4 out of 10. Wait a second. I'm going to put more mechanical stress through a tendon and the patient experiences less pain. This, during your evaluation or during your rehab process, should really kind of put Christmas lights around this patient. Wait a minute, I might have nociplastic pain. And the reason for this is mechanical loading alone does not explain the patient's pain. Now, we don't need to use the word nociceptive and nociplastic all the time. However, when you understand this, it's going to change how you treat your patients. Because a lot of patients with chronic tendinopathies have nociplastic pain. The more you load the patient, the more you move things around, they have a different response. Now, it doesn't mean we're going to stop treating the tendon just because the nervous system is involved. Instead, you really need to think about this as 2 rehabilitation targets. We're still going to build tendon capacity, resiliency. However, we also need to decrease the nervous system sensitivity. Progressive loading can do both. And I'm going to explain this because a lot of people don't want to start loading a tissue if someone's having a lot of pain. And I believe, and the research believes, that's wrong. When you can progressively increase resistance, you can progressively improve range of motion, increase repetitions, improve tempo and speed, and eventually get to the energy storage and sport-specific activity, this is now not only building resiliency within the tissue, which you need to do, but it's also teaching the patient something. Hey, I loaded this tendon. Yeah, it hurt a little bit. Nothing terrible happened, but I recovered and now I can do more. Education becomes the important part of this treatment. If I look at the average person with a sprain or a strain, I don't need to educate them that much. I just need to start rehabilitating. I need to loosen things up. I need to keep things loose and let the tissue heal. When it comes to nociplastic pain and someone with a tendinopathy, your education is part of the treatment. And that's what I'm going to cover at Dr. Donahue, because this is where our language becomes incredibly important. I would never tell the patient, hey, your tendon's fine. The pain's just in your brain. Instead, consider this. Hey, your tendon's sensitive. but it's not fragile. We're going to improve the capacity of that tendon. We're going to teach you and teach your nervous system that progressively greater loads are safe. You're now changing the meaning of pain. They're not going to just stop the rehabilitation exercise when they have the first inkling of discomfort. So in essence, we want to combine progressive tendon loading. We want to combine graded exposure and pain education, general physical activity. These are all important things in the cases of tendinopathy. If we do these things appropriately, now we can not only get people out of pain, we can keep people out of pain. And then hopefully, if the patient does go into a similar kind of situation and hopefully another joint or muscle or tendon, they don't keep on re-injuring the same thing over and over again. But as we can do this, we can teach the patient what safe, acceptable amounts of pain are and get them to keep on doing their activity or their sport that they love. Now, the reason I bring this up is I do want to get into this conversation with Dr. Donahue, and this is important in our understanding. In the case of Jack is my 18-year-old son. He's been playing soccer since he was 5. Even at 5, he was playing year-long. Before I get hate mail, we still made him do all the sports, but this is a sport he ended up with going through high school and now playing in college. And he had a hamstring tear. Now, I'll go into the details with Dr. Donahue. However, this was an immediate moment. As a father, as a provider, I knew I needed to get him back on the field as fast as possible. It's a senior year. He's got college coaches coming. I need to make sure I do everything possible. And that's where the conversation with Donahue is going to pick up right here. All right, so now I've got Dr. Brennan Donahue here, and I've got a couple connections to Dr. Donahue. One, we just had a great weekend in Sonoma, California with the MCM group. Thank you, Kevin Christie, for putting on such a great group. 2, we both went to Logan, so I guess you can't hold that against either of us. And 3, I know your family kind of well. In fact, right. A lot of your in-laws are people that I know over on the Illinois side, so we have a couple connections here. That's not why we're here, though. The reason we're here is because I have an 18-year-old, and the 18-year-old was running down the soccer field as fast as he thought possible and tore his hamstring. And I realized 2 things in that moment. One, I was under-equipped to treat a hamstring injury because I normally send these things out like frozen shoulders because they take so long. It doesn't really fit in my practice model. And then 2, I hate treating family. I can't stand it. They look at you like, why haven't you healed me yet? So I brought on Dr. Donahue for this podcast because he helped successfully manage a hamstring injury. And I think I want to dive a little deeper into that and give understanding not only into what happened with my son Jack, but also dive into some things he did with him: soft tissue manipulation, ancillary therapies like Shockwave therapy, and then kind of have a conversation on how he does those things in his own practice, not specifically because he runs his practice to treat my kids. So, Dr. Donahue, thanks for being on the show.
Thanks for having me. And it's a small world. My wife's family has been seeing you and Dr. Bartelsman for way longer than prior to me even starting chiropractic school. So it's a small world when universes collide.
It is kind of funny. I think that was when we saw her in MCM, I looked at her, I'm like, I know you.
Yeah.
And I just forgot that you guys were married. So let's get into managing. We're gonna talk about lower extremity tendinopathies, but we're gonna have a focus on the hamstring. I think that's going to be the main thing because it is a prevalent problem, and it is a problem that does take unique knowledge, not only in the treatment, but also in the patient education and meeting your patient's expectations. So, when you start to see high-level athletes with stubborn lower extremity tendinopathies like a hamstring, a tear, partial tear, whether it's in the belly or the tendon, what kind of things do you do for them? Kind of walk us through the roles of repetitive loading as far as rehab. What kind of strength deficits are you seeing? What kind of recovery things are you doing with these patients? What is happening to these patients, and why do they have these hamstring injuries?
I think that there's a very complicated situation there, right? So a few things is we definitely monitor: is it an acute situation? Right? Is this a brand new tear, or is it the tendinopathy that's been there for a prolonged period of time? We're definitely assessing. Everyone throws these into the overtraining bucket, right? And when people think overtraining, They just think that pure volume is all that we're considering when we need to consider intensity, training surface, anatomical mobility. How's the spine moving? How's the hip moving? Are they going into deep hip flexion, which is causing compression and leading to is there any overstriding that might be happening during their running gait?
We had this conversation about overstriding. I want you to dive in that just a little bit deeper because a lot of people run with partners.
Right.
How can that be a detriment to someone with a hamstring injury?
I have read a few articles out there that just talk about stride length and how we sink into a stride length with the people we're running with. And some of it talks about how the foot smack, they try and line up when everybody is smacking the ground at the same time. But a prime example, you take a 5 foot tall, let's call it female runner, and pair her with a 6 foot tall male runner. They are going to have different anatomy and a different ability to stride. And so oftentimes, most people will begin to overstride before the taller person shortens their stride to keep up.
Gotcha.
And so it's fascinating that overstriding and that relationship with especially high hamstring tendinopathies.
Yeah, I think that's one of the hardest things to do is to change an activity day living. You'll see patients who will, I always tell people, as far as dietary stuff, I'd rather change your religion than change what you had for lunch because people are so used to doing something over and over and over again. But especially when you get into an athletic activity, they're used to throwing a baseball the same way. They're used to running a certain way. So when we get into after they come in your office, they have a hamstring injury, what should we be telling these patients? Once you've gone through, and we'll talk about the evaluation in a second, but let's say they do have a hamstring injury or a chronic lower extremity tendinopathy. What are the hardest parts to tell that patient about this healing process?
Hardest part is laying out a timeline and sport modification. I think we know that tendons take significantly longer to heal. 2 weeks is not enough time. That's what they expect. We need to be able to set the stage for them that we're not shutting you down for the length of time I'm about to say, but you need to know that this could be going on for multiple months as we work through the process of reducing pain, increasing range of motion, and building strength back up.
One of the things that I'll get with patients is that's not good enough for them. They want to get another opinion. They want to do PT. They want to work with their trainer, what have you. How do you handle those relationships? When someone's like, hey, can I do this, but can I also do something else?
I never stop them from going through those options. Laying those options out is good. I do express to them that too many hands in the cookie jar can be a negative thing, right? They want to come to our office to get Shockwave, and then they're seeing a massage therapist tomorrow, and then they're seeing physical therapy who wants to dry needle them on Wednesday. And some people go all in, but I think we know that tissue tolerance is a word I use in here often. Too much load to that tissue by every different provider under the sun is not going to allow for that tissue to heal properly.
Okay, so someone comes in with a lower extremity tendinopathy, and your goal is to get them back to their sport as fast as possible. What are the stages of getting back to their sport? Meaning, what do you allow them to do at the beginning? Is it just doing rehab? Do you allow them to start to do something more advanced? Like let's go on the hamstring. So what are your phases to getting back to return to sport?
Yeah, I think the end goal is obviously return to sport without limitation, right?
Yep.
We try and mimic that the best we can as we are moving through our treatment plan of our rehab of box jumps and lateral hops and trying to include multiple planes of motion during our rehab. Early on, it might be like you threw out, isometric load just to get some things firing again, without reproducing the inflammatory response. As we decrease a patient's symptoms, they're reporting less pain throughout the day, then we start moving into eccentric, concentric loading before we move into plyometric. And even before plyometric, the heavy, slow resistance training to help them get length under load before we go into jumping and running and cutting and things like that.
Yeah, I took a Stu McGill class when I was in school, and he worked with a lot of professional athletes. He's like, never beat the athlete. As soon as you start to challenge the athlete and you beat them in you say, oh, you can't do this, then you're psychologically damaging that person. However, if you let the athlete find their weakness, then they know. They know. They're like, you know what, you're right. Maybe I should take another week off of running. And I think it's interesting when you come into tendons, because tendons have different amount of load bearing capacity throughout the architecture of that tendon, where you can do most things. However, that one thing, that one maneuver, that one cut to the left, that one kick, whatever it is when you load that specific part of the tendon, and they can feel that. So yeah, you got to be 100% painless, in my mind. Now, if it's the last game, it's your senior year, and you want to tough it out, you're not playing college, do what you want to do. But otherwise, let's protect the kid, for the long term. Evaluation and imaging. And this is I think one of the hardest things to do as a chiropractor, not the evaluation part, but the imaging part. The imaging, people think that chiropractors always take x-rays of everybody in full spine and do it every week. And I actually think we under image our patients when it comes to the research. However, when it comes to soft tissue things like this, how are you taking an athlete and saying, through your orthopedic examination, through your history, okay, we should be doing this to begin with as far as conservative care, or we should be doing an x-ray, or we should be doing an MRI, or I think we talked about earlier in the case of soft tissue, an ultrasound. So when it comes to a hamstring issue, what is your go-to pathway for imaging to make sure that you have the right documentation of the diagnosis and can relay that to the patient?
We now more than ever jump into ultrasound rather quick. I mean, we are in St. Louis, Missouri, so we're spoiled because we have Logan's Diagnostic Imaging Center right down the street from us. We have people like Dr. Matt Bays, who's been doing diagnostic ultrasound and PRP and stem cell injections for a greater part of his career. And so that's not an automatic release of care from us, but we start the imaging train so we know exactly what structure do we need to hyperfocus on and work around.
All right, I have a couple questions on this, and we didn't go over any of these before talking, but I'm just curious. So one of the biggest hindrance we see with young providers is that imaging delays care, because they say, oh, I need to get this, but then we can't get them in to get that MRI or that ultrasound. So how have you built a network with people around you to make sure that, one, you can get the imaging fast, but two, they're not referring to someone else when they get that positive, finding?
I think that comes with reputation building, right? Respect and experience that you know how to manage the case. I have to agree with you, because early on as a doc, I was almost afraid to send out for imaging if it wasn't absolutely necessary, because if they saw that partial tear, they'll go straight to ortho without, and so being able to speak openly to them of here's what I think you might find on this image that we're going to send you out for, but know that as long as it's not a full thickness tear that needs another consult, we have the tools that'll be able to get you over the hump. This is just the exploratory phase to confirm that our diagnosis is correct.
Well, you answered the second question already, because the second question is that because people put their positive findings and you could tattoo it on their forehead. You could tattoo someone has TMD on their forehead because they tell everyone about it. And now when you get into osteoarthritis of your back, oh, I can't do that because I got a bad back. Well, if we get into especially a student athlete with a tear, it doesn't even matter if it's a partial thickness tear. They see anything, it's, oh my gosh, I need surgery. So the question was, do you preload that? Yeah, and we do in our office. Hey, you got some weakness, you got some injury, we're probably going to see some tearing. So you would also?
I also do. And I also, if there's ever that patient that's uncertain, I talk to them, let's keep moving forward with our treatment plan that we have laid out while you're consulting with an ortho that might take 2 or 3 weeks to get into. And let's reevaluate right before that appointment on what improvement you're seeing at that point.
And then the last question is, why are you choosing ultrasound versus straight MRI?
Barrier to access for us is lower for ultrasound.
I was going to say the same thing. It's cheaper.
Yep.
It's easier. It's faster. And we don't do ultrasound. I'm not advocating for an ultrasound tech. However, we Aaron Welk in the area, Matt Bays, we've got, and Logan. We fortunately have some people that we can ask for those services, and they can do it in a timely manner. All right, let's talk about the actual treatment. I think this is, once you've identified the problem, we know what it is, what role does hands-on treatment play? And the reason I ask this is because, some people think that, manual therapy, like certain techniques break up scar tissue or, do X, Y, or Z. But really, when it comes to a partial thickness tear or a muscle belly tear, when it comes to, the hamstring issue, what are we actually doing with soft tissue therapy? Are we fixing that scar tissue? Are we breaking things up? Are we healing tissue? Like, what do you think we're doing in that situation?
It's been a fascinating topic over the years because I've been full body ART certified for most of my career, and we have found different theories of what myofascial therapy is actually producing, the outcome we're producing. And so even if the way I look at it is, even if it's not breaking up as much scar tissue or trigger points as we once thought, I still see anecdotal evidence inside my office that we're at least desensitizing the surrounding structures.
Yeah.
And the quicker we can desensitize an area, the more, I don't want to use buy-in because that doesn't sound like right, but we're going to build that trust and rapport with that patient a little bit quicker if we can produce a quicker outcome.
Yeah, and I'm not a biomechanist or a physiologist, but one thing that I see is that it does provide that window of opportunity that a patient, in this case, doesn't want to fully extend their leg. Can we get them to fully extend their leg? And by doing soft tissue therapy, whether it's an ART method or something else, it does change that pain signal. Neurophysiologically, we are taking away that nociceptive input. We're not changing the tear. We didn't heal anything, but it is odd how we can change muscle tone so fast and get someone to increase range of motion, increase flexibility so fast that it allows us to get them in a good position, allows us to do the right kind of rehab. Whether we're doing something structural or not, I don't think so. However, it does allow us to do the therapies we need to do and the rehab we need to do.
Correct.
Ancillary treatments, which is why we're why we're here, is that I didn't have a Shockwave unit. In fact, a new associate of mine was a past preceptor of yours, and she let me know that you had a Shockwave unit. My son just tears his hamstring. I go to Dr. Bays the next day, so I'm sure he doesn't listen to our podcast, but Dr. Bays is an orthopedic surgeon, a friend of mine. We work on the soccer field together, and Jack does it right in front of him, and just by happenstance, I literally get him in to see him the next day. We do the ultrasound, and fortunately, we're allowed to do PRP immediately. And as a crazy soccer parent, which I'm a self-identifier, my kids do not eat unless they score a goal. It's just the way we work in our family. I thought to myself, what else can I do? What else can I get done to my son to get him back on the field as fast as possible? Well, I did a little bit of research and got on ChatGPT, got on Chiro Up to the condition reference section in the research review section, and laser. Dry needling, shockwave therapy, whether it's radial or focused, blood flow restriction, all those things were kind of on the horizon for him. And I didn't do any of those things. None of them. Zero. Now, my associates do dry needling. However, I was like, man, am I under-equipped for this? And so I found, I shot you a call, and fortunately, we were able to get him in. So kind of walk me through a hot hamstring injury, inflamed. What did you start doing with him?
Yeah, when we talk about that hot hamstring, one, laser, right? Really good at pain, reduce pain, but we also can utilize shockwave in and around that tissue. Not at the site of injection of PRP, right? We don't want to use that for a few days, but we can start working through those secondary trigger points that we know occur after that big recoil. That big push, acute pain, and now he's hobbling and limping. And so the kinetic chain starts kind of breaking down on us a little bit. And there are times where we'll also, not in the acute, but that more chronic hamstring injury, we'll also implement dry needling, produce localized bleeding in the area and things like that. So, with Jack, I believe we went straight to shockwave, straight to laser, and did a combo of that to not only break up secondary trigger points, but also promote as much physiological healing as we can in that area.
Yeah, and I think it worked a little too well, or maybe I over talked it because he thought he was, within a month, he was like, yeah, I'm 100% ready to go.
Right.
He wasn't by any means. Right. However, it does speed things up. It does decrease pain. It allows him to walk up and down steps, get in and out of his car a lot easier. But there's still a tissue healing component that I think that, we had to educate him on to give him a better expectation of how long it actually takes, tissue to heal. I do want to talk more about the Shockwave aspect of it because since we had that experience, I've since bought one. I used Kines Medical. You did too? And had a great experience, and I have no affiliation with them, but I don't think it really matters who you use. I think buying a good unit, a good company matters the most. But I do want to talk about the training aspect because this sounds so bad, but I still don't know how to use ours. We've had it for 9 months. And it's not that I don't want to use it, or it's just that it's been a great tool for my associates. Actually, in full transparency, it's a great way for me to treat the patient and then for them to meet my associates while doing our therapy. I know one issue we had when Dr. Berlesman started backing away a couple hours from clinical practice is that patients didn't want to see anyone else. And it wasn't that the other associates in our practice were bad. And you're in the same situation with preceptors and associate doctors. Right. They want to see you. They don't want to see someone else. So I thought it was more interesting. Not that I'm lazy, but I wanted them to do the training. I wanted them to have the understanding, them to do the actual work versus me. Where did you get your training, understanding how to use the tools, understanding the importance of Shockwave, understanding which types of diagnoses to treat and different techniques for those? Where did you get your information?
After the purchase, I didn't use anyone for about 2 years before I finally went to
so I've still got time.
And you have time. And so, I think we used it to our best knowledge as we could after we bought the machine. And then I did attend the Academy of Shockwave Excellence course down in Atlanta, Georgia. And
what does that cost?
Rudnick, Dr. Ben Fergus, they're all instructors for this course.
What does that cost?
I cannot remember. I want to say $1,200, but Please don't quote me on that.
Yeah. You heard it here first.
But yeah, and I'll tell you,
we got a coupon for that for $1,200.
We recouped that in the first 3 weeks I was back from the course with the knowledge that I learned of how grossly underutilizing we were of the treatment.
Yeah, I think that's one thing that I'm going to send an associate down to do that class. And once again, it's not because I don't want to learn about it. It's that I really do think that it's interesting in a multi-practitioner, I guess we can call it, practice, on how important it is that your patients see, understand, have some kind of interaction with all the providers there. And that's something that's been just at least big for us. Rehabilitation. So let's talk about this because I know with Jack, we started off really slow with doing some just isometrics, isotonics, but really we need to get back into progressive loading. So what is your typical rehabilitation program for this kind of hamstring issue?
I think with this, we usually will start people off with isometrics, control the joint motion while under load. And make sure that we can at least tolerate some of that load before we start moving. Hamstring crosses the hip, crosses the knee. We have multiple joints in play here. And so then we will slowly start, once the symptoms calm down, they can walk a little bit better. Now we're starting to go into more eccentric loading, followed by concentric, and then some just slow resisted weighted work, higher than body weight. And I think, I believe this might be a Thomas Showed topic, but walking is only 1 to 1.2 body weight. When we're talking running, and that running in a straight line is about 8 times body weight, what happens when that kid is in cleats on turf and going to pivot and forcefully push off to go defend a ball? I think that number only climbs greatly from there.
Let's not bring up Thomas Showed. That last podcast with him, like my brain almost exploded. He talks so fast and is so eloquent in the way he delivers information. You're looking at him and you're like, there's no way he's not reading something. And I'm watching him because we did it on video, and he's just spitting off information. If you haven't heard that podcast, please do. And not even so much the podcast with me. That was pure selfishness to get him. Like I was just excited for my own questions. He's got some great ones with Gestalt education. He's just a 10 of a person. However, back to this podcast. I think that's one of the hardest things that I want to touch on right now. If you get a patient who has a chronic issue that we need to do some kind of progressive loading for, it doesn't matter if it's a bicep issue or posterior tibial tendon issue, whatever it is, and they come into you with pain, and you know that by doing eccentric loading, you're going to do what? Induce pain, right? Or induce discomfort. Let's just say that.
Yeah, correct.
How is that conversation going? Like, hey, I know you have pain, but here's what we're about to do.
There's so many layers to that, right? And it's hard. It's hard to look at a patient and be like, we're actually trying to cause some irritation to that muscle and tendon. We usually let people, the way we word it is, as long as that soreness is there for less than 48 hours, I'm totally on board for that. It's when it starts extending into 72, maybe 4 days. Okay, now I'll take the blame. We went a little too aggressive too soon. We are not abandoning this theory. We just have to reduce the load and strain on that for shorter periods of time.
Perfect. I'm the exact same way. And I think that if we don't have that conversation with the patient and they start to do their exercise and it hurts, they're not going to do that exercise anymore. Going through all the exercise we have, in Chiro, the two that I had Jack do at the very end to kind of show me he's back to health, which proved to him he's not ready to go back to soccer, was the eccentric hamstring strengthening and the Copenhagen adductor strengthening. Have you tried that?
Oh, they really get you, won't they?
I need to go back and look at that exercise. I haven't looked at it in a while because here's the funny part about that exercise. And I think it's still me. If you go on that exercise video, it's me doing the exercise. Whereas obviously we have my wife does all the other exercises. She couldn't do it. And she's a marathon runner. It's a very different exercise. And what do adductor injuries and soccer players have? I mean, those two are peanut butter and jelly. Yes. So yeah, two exercises that I would at least consider, for these kinds of patients.
And I think one thing I'm going to throw in too on the rehab side is I think a lot of people think as cycling is a great mechanism of cross training, but what position does cycling put us in?
Yeah.
Deep hip flexion, bent knee. So those are the conversations that we try and have with our patients of, all right, actually I want you on an elliptical because we're not going to go through as much hip flexion and you're not going to get as much strain down through that hamstring.
Yeah.
And so it is getting to know the patient on what they're doing outside of your in-office rehab to make sure that they are not going home and causing more irritation and complicating the whole situation.
Oh, I can't imagine a patient complicating their own situation.
Never. You've not seen it.
It's tough because whenever a patient walks in my room, I look at them straight in the face and I'm like, this is your fault. In the absence of a car accident or a trauma. However, patients don't want to take, blame for whatever happened in their body, but it was their hobbies, their habits, their activities, their sports, whatever, that cause their problems. And I think more than just this conversation in today's world, at least in my practice, it's not even an activity. It's a lack of an activity. It's sitting or laying down for too long.
Yes,
all right. Last section that I want to cover is marketing, because this is one of the hardest things that I think that chiropractors have to do is to market their great results. And we would love to believe that every patient that walks out of our office after we do the phenomenal job he did with Jack, that Jack's going to turn around and tell his medical doctor. He's going to tell his parents. He's going to tell his neighbors. He's going to tell his teammates. They don't tell anyone. Nobody. There's so many times that people walk in my office and like their son is sitting in the waiting room like, oh, I didn't know you went here. Like nobody talks about the chiropractor they see, which is unfortunate, but also they don't talk about the great things that we do. So what kind of system do you use to help market the great results that you get?
I think one of the best marketing systems is practicing what you preach at times. And I know not everyone can do that, but my belief is if I wanted to work with athletes, I needed to be out in the trenches a little bit doing some of these things that my patients are doing. Let's call it street cred. You're getting that credibility while you're out, you're training with them. You're running with Bob, who starts talking about how good he feels after a few visits. John on the other side is like, what'd you go to him for? And so there is that community that's built when you're out in the trenches a little bit. I also am a firm believer that if any of my athletes have coaches, my youth athletes have parents, there have to be open lines of communication with those people. I know in the mundaneness of chiropractic, we're going from patient to patient, make a list, have a staff member write a list of all the coaches or parents you need to call at the end of that day. And I do not leave the office until I've contacted those coaches. And coaches, maybe not in youth sport, but an adult endurance coach, should I say, and give them an update on what we're seeing in clinic, some recommendations or modifications that we should be considering. And I try my best to make sure that I'm not stepping over that line into acting like I am a running coach or a triathlon coach.
Yeah, knowing your limitation.
Correct.
You're not telling them what to do,
Correct.
just what you know and how they can help
Correct.
get this person back to their sport. Have you ever, this is not on the hamstring, but do you ever call your new patients after every visit?
We have returned to that. So I used to, when I was a younger doc, I would do it. Our current model now is we have a patient care coordinator who within 24 hours after that first patient, she's calling just as we call it a courtesy check-in. How did you respond? Did you experience any soreness we talked about? What benefits have you seen? And are there any questions I can pass on to the doctors?
I'll tell you what, that is in my opinion, that's very smart. We do the same thing. And what's interesting is you'll hear a couple things, and those are the reasons why that patient may not come back. One, they don't understand why they have to. Maybe there's something misunderstood in the office, or maybe they're very sore. But having that contact, and then what we do is if there is a conflict, a friction point, whatever it is, hey, I didn't get my exercises. Now we can immediately text those over. Or I didn't understand my diagnosis. The doctor can get on the phone call and talk to that patient. So I think that's very smart. Anything else you want to cover about hamstrings? I think that we kind of covered it all as far as what happens, when we're going to do imaging, what we're going to do as far as rehab, what are we going to do to manage expectations, what we're going to do as far as marketing and training versus Shockwave. Any other pieces that we missed?
I think we covered a lot here, and I just want to end with make sure that you're being the guide for these patients. That people are coming to you wanting someone to take over and manage whatever is bringing them in the door. And I think that can be missed at times if we're too hyper-focused. And so stepping back and seeing their whole quality of life and things like that can go really far. And a little plug here for Chiro Up. Those condition reports do go a long way. That we use those, and that goes into the marketing and the feedback we get of people that just state, and now the app and the way that they can access their exercises and we can plug and play and update, that does go a long way with the way that we run our office here at Active SCL.
It was so funny. When Jack came in here the first time, he said, Dad, I got this text message for my appointment and then I could access my exercise. I'm like, Jack, that's what I do.
That is hilarious.
And then about maybe 6 months ago, my wife was at dinner. She's like, Brent, you should start doing a podcast so you could start to, get the word out about the car. I'm like, I have for the last couple of years. So it's so funny the things that we do that we think everybody knows that we do. Now that's Chiro Up, but even as a chiropractor, when someone comes to see you for back pain, you're the back pain doctor. When you're fix a hamstring, you're the hamstring doctor or the running doctor or whatever it may be. So make sure that you can educate your patients on all the things you do. Thanks for coming on the show. I think that having guests, I have fought for so long on this podcast, and it has nothing to do with the guest. It's the scheduling. It's the, going back and forth on a script and, the questions that we're going to ask and the expertise. But what we settled on was finding people who actively participate in the Chiro Up EHR, who are content developers, who are users, who are advocates, who are high on the support queue, meaning they constantly give us feedback, which we love with Chiro Up Vote. So if there's more things you want to hear about when it comes to the podcast sections with our guests, please let me know. As always, you can do it via support or Chiro Up Vote, or you can just email me, Brandon at Chiro Up. Otherwise, thanks for jumping on the show.
Thanks for having me. It's been a wonderful conversation.
Well, I hope you enjoyed the conversation with Dr. Donahue. I left that conversation after taking a lot of notes. It was funny that we got into the conversation with Dr. Michaud because during all my guest segments, I'm constantly writing down. Yes, I still use paper and pencil. That's not true. I use a pen, not a pencil. However, there's a couple things that kind of stuck in my mind that I didn't want to cover with him. I wanted to go back and kind of understand it and then come back on the podcast and cover it with you. Because adding services, especially when it comes to Shockwave, is it actually worth the time? Is it worth the money? Is it worth the effort that we're putting in? Because buying the equipment, in this case Shockwave, doesn't answer these questions. You still need systems for tracking utilization, conversion, revenue, cost, and provider performance when it comes to these services. So I want to cover three things that I wrote down that I want to provide a little more context to, and that I actually went back to the practice and changed within our practice. So one of the things is, if in this case a Shockwave, make sure you give this service its own identity in your EHR. Create a separate room for it if you can do that within your scheduling, because this is going to help you run better reports. Also, if you have a specific provider specifically is going to do Shockwave, that makes it a lot easier for compensation, which I'll cover in the next couple sections. However, we want to see how frequently this equipment is being used. Everything is being rated. Everything is being measured, especially when you think about bringing on a provider, massage therapist, or Shockwave or dry needling. It costs you money to have square footage in your office. So we do need to have an understanding of how frequently the equipment is being used. Does it require enough space? And are you using it enough? Do you have enough utilization to justify the investment? So that brings me to number two. How do you track utilization for this? How do you justify the revenue? I use a service code usage report, and I track this on a weekly basis. We're an EOS shop as far as our practice at Premier Rehab, and if it's important to you, you're going to measure it. And if you keep these numbers on a spreadsheet and everyone on your team sees this, especially when it comes to Shockwave, I can see the number of introductory sessions. I can see the number of packages sold. I can see the number of treatments performed, gross collections, and utilization of the machine, not only for cost purposes, but also when I need to maintenance this machine. So these are pure mythical numbers. However, let's just say if the introductory fee for your Shockwave is $50 and the treatment package you sell is, let's call it 6 visits for however many dollars, 80, 85, let's call it $500. These are important numbers because you need to figure out what your package conversion rate, which is essentially how many packages did you sell divided by the introductory sessions. If you perform 40 introductory sessions and sold 24 packages, that's a 60% conversion rate, which is math, right? There's supposed to be no math in chiropractic. However, consider this. Who is selling your packages? Is it you? Is it a staff member? Is it all the different providers? Because if you can now break down per provider their conversion rate, it really is going to help you understand which provider should be helping you in that service as compared to other ones. And let's say you do have someone and you're dependent on that one staff member, that's okay. Maybe their conversion isn't good at the very beginning. Send them to a class, have more education pieces with yourself to increase that conversion rate. That brings me to number three, is not only do you need to educate your staff and the salesperson, but also educate your providers on this communication. Don't just teach your providers how to perform Shockwave. Teach them how to explain why they're recommending it. I consider it the fence mentality. I was in a meeting with HSHS, which is a medical system in the St. Louis and Illinois, well, I guess mostly in the Illinois side. And they talked about, well, we don't really refer to chiropractors because you're not in our fence. Meaning if someone is having pain or a problem, they're going to send to PT. If they don't get out of pain, they go to pain management. If they don't get out of pain, they go to orthopedic surgery. If they don't get out of pain, they go back to the medical doctor and then repeat that process over and over until someone gets upset and leaves the fence. Well, think about that in your practice. If you're providing manual therapy, manipulation, exercise, and you reach a point where they've plateaued or they're not getting better, how do you prevent someone from leaving your fence? What other things can you offer a patient? Whether it's dry needling, whether it's Shockwave, whether it's someone else in your office, massage, trying to keep people in your fence becomes extremely, extremely important. So if someone is getting ready to leave your fence because you're not getting out of pain, make sure that, hey, we have Shockwave. This is designed to do this. Here's how many sessions are typically recommended based on the research. Here's what you should expect. Here's why we're completing a treatment plan. Here's why it matters. And then track the provider and use these numbers to coach them to do a better job of education. Remember, patients don't leave your care because they just forgot to come in. They don't understand why they have to come in. If you front load that with education, they will complete their treatment plans, especially when you have packages out there. Now, number 4, which I will 100% admit, we did not do very good until this interview I did with Dr. Donahue, is build a follow-up in the process. So what we do now is we have a 24-hour follow-up call or text after that introductory treatment to ask the patient how they're doing, to answer questions, to reinforce a treatment plan. I think that this is one of the things that maybe was lost at the very beginning. We just assumed people are going to come back. Also, we started giving patients a professional handout they can take home. It doesn't matter if it's Shockwave or massage therapy or dry needling, whatever it is you're offering. However, if you have them consider a cost for some kind of benefit, they're discussing that $500 decision with their spouse, with their family member later that evening. Giving them something to bring home is going to matter. That's why we created condition reports in the first place with ChiroUp. They're going to look on their Google machine. They're going to get on ChatGPT. Is this machine or is this service going to help my tendon? Is it going to help my pain? Making sure that you have the right terms on this brochure so they search the internet properly. Next, calculate the true cost of this service. One thing that I've become to realize as I've become an owner in the practice is revenue is not profit. So just because we have revenue, that doesn't mean that I go home with that revenue. It's really about margins. Your spreadsheet should account for purchasing this product, for financing this product, the maintenance, the repair, the supplies, the staff, the merchant fees from the credit card, the marketing cost, the creation of the brochures. How do you provide compensation to your providers? Think about all these things because Shockwave revenue is not Shockwave revenue. Shockwave revenue is Shockwave revenue minus direct costs, minus equipment costs, minus compensation. These are all the things you need to think about when it comes to margin. These numbers tell you much better whether service deserves more investment. There's a ton of things I could add to my clinic, but I'm not either educated enough or there's not enough margin in it for me to consider for my patients. Shockwave, dry needling, certain supplies like Archipor, some toe pros. I have certain things in my office because they have margin, not revenue. Now, the last one is build in compensation for the people who are performing the service and do this around those margins, around the profit. Don't do it around how much you charge the patient. This compensation model should not just focus on the dollar collected. So let's just say this, let's just say that in your office, you pay your providers 40% of collections. So they get 40% for every dollar they bring in for Blue Cross Blue Shield or Medicare, whatever it is. Don't do the same for these types of services because they do have extra fixed costs associated with it. So we have a compensation calculator that really helps you establish different reimbursement rules or rates based on the service. Maybe someone does get 40% compensation for their typical billable services, but if it's a supplement, we can actually increase it to 90%. If it's Shockwave, we can have it at 60%. Whatever it is that works for your office. Don't just blindly create a compensation model that's one number across all services because of the things we talked about. They have different margins. And I think if you can understand that, then we can start to have these discussions with our providers. I know when we incorporated our compensation calculator, I've used 5 different EHRs in my past practices. We just paid a flat rate to all of our billing companies. I was losing hundreds to thousands of dollars a month because I couldn't carve out billable versus non-billable services, PI services, work comp services, supplements on the same invoice as a billable service, supplies on the same invoice as a billable service, because billing companies take the entire amount that was collected and you get a percentage of that. Well, what if they had no say in that collection? What if it was a pure cash rate like Shockwave or dry needling or their arch support? They should not be collecting the same. So this is one thing that make sure the numbers in your EHR make sense, are reliable, and reflect how you do business. And then finally, put all this stuff on a spreadsheet, right? Things can change. You're not going to ever design the perfect process, but iterate. It doesn't matter what it is as far as the providers or the compensation rates. If it matters to you, measure it. We only have about 12 metrics that actually run our entire practice. Everybody's responsible for one of those metrics, and they better be accountable for that metric to make sure it makes sense for the practice. I hope this podcast was entertaining for you. I really enjoyed getting feedback from Dr. Donahue, and I'm trying to go back and understand not only all the different changes that can happen to tendons, but what happens when we don't have all the answers for a tendon or a tendinopathy. What other services we provide, like shockwave therapy? And then most importantly is we run a lean practice. Is this a profitable add-on or expansion service that I can provide to my practice? Thanks for listening. As always, if you like these kind of shows, these podcasts, please like it, share it with a friend, post something you learned about it on Instagram. We actually have one of the largest chiropractic Instagram accounts, which is kind of fun to know. Just the amount of people that we're reaching. Not only are we reaching the subscribers, but we're also reaching their patients, because it's not just provider education we put out, it's information that your patients would like. So I appreciate it if you like it, that. Also, if you have an idea for another segment or a guest, please let me know. We do only take people who are current subscribers to Chiro Up or are contributors to Chiro Up. So if you know of one person like that you want to hear from, please let me know. My email is brandon@chiroup, and I look forward to hearing from you. Thanks.